We shall now move on to our next speaker, Dr. Manjul Tripathi, who's an associate professor, and he mostly specializes in gamma knife functional neurosurgery. He has also done fellowships, and his specialization is in functional neurosurgery, gamma knife, and neuro-oncology and neurotrauma. Over to you, Dr. Manjul.
Thank you, sir. Thank you for this wonderful introduction. And I'm sincerely thankful to the WFNS committee and especially to Professor Dev Pujari, sir, for providing me this opportunity to speak on the role of the stereotactic radiosurgery for the craniopharyngioma, which I believe that still is a Bayesian viewpoint. We have just heard leaders of this field, and I think we share the same kind of the frustration. So these are my disclaimers, and I am sincerely thankful to my team members, Aman Sonik and Dr. Sandeep Mohindra. Interestingly, it was one of the first disorders for which I was asked to do a bedside as a naive neurosurgery resident. What I can summarize about the impression that I had on that long night, and which has not changed so far, is that it's a challenging and a mostly frustrating disease. Ironically, it's a benign disorder, but it's a wolf in the sheep's skin. I do not deny that the complete resection is a reasonable goal. I am a micro neurosurgeon, basically, so that's still true. But I also believe that it should be elegant, safe, without creating a deficit. If you went with plan for a gross total resection, have a residue, go again and resect the remaining if feasible, but not at the cost of giving the complications, as Dr. Boop told in the earlier meetings. The complete resection comes at a cost of visual deterioration in 19 to 35%, a serious endocrine dysfunction in majority of the patients. And the Prasad et al. Reviewed the surgical series of 28 years and found that only 35.5% could achieve a radical resection. And out of these, the tumor recurred in around 50% of these patients. Now we believe, which Dr. Jalali just told, that we should follow the middle path, subtotal resection followed by the postoperative radiation. That's a better management option. The goals of the strategy are initial surgery for the pathological conformation, surgical decompression. Long-term goal is improved neurocognitive, visual, and endocrine outcome coupled with the tumor control. And the smaller tumor volume improves long-term tumor control after radiosurgery. So the bottom line is to do maximum safe resection followed by the radiation. And often we follow the multimodal management to achieve the best treatment outcome in the different domains. But the literature is still short on the predictive markers. I am still looking for that eureka moment. The presence of the large chunky calcifications may indicate an inner tissue and may not warrant any further treatment. Despite its sometimes worrisome appearance of the large calcified, they just follow a very benign course. The biological behavior of the craniopharyngiomas varies from patient to patient. While some remain stable, others grow during an erratic period of time. Molecular behavior of these tumors may help guide adoption of the strategies based on the genetic profiling, as has been told by the previous speakers. But the long-term results of the gamma knife radiosurgery, which we have since 1960s, 70s now, which show that the tumor control rate, the progression-free survival, that can be achieved in around 65 to 95% of these patients. And in a systematic review, the Yang and colleague, they have found that although the gross total resection provided better tumor control in the long term than the subtotal resection alone, but there was no difference in the overall survival between patients who underwent gross total resection and patients who underwent subtotal resection followed by the radiation therapy. Menity et al. Reviewed the 8 published studies to evaluate the radiosurgery outcome in patients with the craniopharyngioma, and at a median follow-up of around 57 patients in 57 months in 252 patients, they reported a progression-free survival of 69%, with a 20-year experience of 135 patients with a median tumor volume of 5.5 cc and a marginal dose of 12 gray. The new hormonal deficits developed only in 8%. Progression-free survival was found 44% at 10 years, and the overall 10-year survival was 84%. The Nagoya group treated 98 patients with a mean tumor volume of 3.5 cc with a mean marginal dose of 11.5. Tumor control was achieved in 80% with a complete response in 19%. The complications, there were some, majority were the endocrine in 6% of these patients. As you can see, there was a tumor and it showed a beautiful reduction in some time. The same group updated their recommendations, and they, with the further 29 patients with a follow-up of 91 months, they told that the tumor dose of 11 to 12 gray was a good buy, with a complete response in 69% and 90% of the tumor control, with no new hormonal deficit in those patients. So despite so much of the literature, the prognostic factors pertaining to the progression-free survival remain poorly understood. And on this multivariate analysis, they could find that the factors which were actually significant were tumor volume at the time of radiosurgery less than or equal to 1.6 cc, absence of the visual field defect, and the marginal dose prescription more than 14.5 gram. With respect to the pituitary function, the response of gamma knife had been found pretty effective. There was no new onset hormonal deficit in more than 6 to 8% of the patients. The worsening was found only when you couldn't separate the pituitary stalk and there was more than 12 gray doses used and it was spilling over the pituitary stalk. If the patient was hormonal beforehand, then it would remain unchanged. This was a good study from India, which found that in the long term, there was a good endocrine outcome and the visual deficit was found in the later series when the tumor actually showed a long-term failure in those cases. There is a share of complication with a morbidity of 4%, mortality of 0.5%, and this is dependent on the patient's age, size, and the radiation doses. The tumor progression after gamma knife is a function of the enlargement of the cyst rather than the solid component, so that was another problem. And there are some practical questions with the gamma knife radiosurgery for these patients. When to apply, as Dr. Kalali just told, the radiation shouldn't be used as a primary treatment, and it can be used as a secondary treatment following a subtotal resection, following a cyst aspiration to the wall, following just a biopsy, or sometimes as a salvage in the recurrent diseases. There is a very little literature available on the natural history of a recurrent or a residual craniopharyngiomas. A radiographic gross total resection in different series has been achieved in around 16 to 100% of the patients. And within 2 to 3 years, 35% of these patients after the primary surgery, they have shown a recurrent lesion. 80% of these patients needed a hormonal supplementation because of the initial insults from the surgery or from the disease itself. So what if I have a residue? Because the subtotal resection, when you do, it results in the progression rate of 55 to 85%, and that happens in a very short period of time. That happens within few months to a few years. And the addition of the post-op radiotherapy can reduce the recurrence rate to 15 to 20%. There is no phase 3 data available over it. The Regine et al. Reported 78% survival rate at 20 years in children treated at the time of first diagnosis, as opposed to 25% of the patients which were treated at the time of the recurrence. However, this could not be observed in the adult subgroup, and in fact, several studies found no difference in the local control reported in the pediatric patients directly after the neurosurgical intervention after the primary diagnosis, as opposed to the patients who were treated when the tumor showed a recurrence on the follow-up imaging. So the recurrence rate after subtotal resection varies from 30 to 100% with an average of 65%, but if you add an SRS, it reduces to around 17%. Mazda et al. Published a beautiful paper in the long-term history, and they found that nearly 19% of the patients have no recurrence even at the 18-year follow-up. So I do not know which patient should receive it or which shouldn't if they just come with a single MRI after the surgery. So there is no predictive marker. The progression occurs early after STR within the months to few years. So I just get a 6-monthly MRI in those patients. Now, again, the question. There is one scenario when we attempted the gross total resection but resulted only in STR. So if the surgeon thinks that the gross total resection can be achieved again, it can be done. Yes, it can be done, but the chances of the complications again increases. I simply agree with the Rick Boop's opinion that we should avoid multiple procedure in these patients. And the subtotal resection followed by the SRS provides a superior endocrine outcome, and that has been proven in multiple of the studies, including this beautiful study by the Gopalan et al. And the Persat. So relatively modern series show effective salvage of the patients with the recurring disease, and it appears that the use of SRS at the time of recurrence or progression yields local control rates similar to those achieved when the SRS is used in the early, that is 1 to 3 months post-operative. Furthermore, overall survival remains high, that is 85 to 100% in the salvage groups, which show an increase in the tumor at the recurrent follow-up. And given a median time of progression of only 12 months in patients with the subtotal resection, there may not be any advantage gained with this approach, except for the young children who may benefit from a delay that allows further brain development. And these children should be followed closely with them are emerging and treated with SRS at the first sign of the radiographic progression. The rest of the parameters remain same, whether you give early or you give at the time of increase in the tumor volume. The cost of the delayed salvage therapy is the increased risk of the endocrinopathy and probably an increased risk of the radiation-induced optic neuropathy, because probably the lesion at the time of the progression when you give the radiosurgery later on has increased in size, it might be nearer to the optic apparatus or nearer to the hypothalamic pituitary axis. And in those cases, the chances of the collateral damage actually increase. The typical response to the radiosurgery is an initial progressive loss of the central enhancement, then the cystic changes, and finally the tumor regression. The question of how much dose is actually sufficient, there is no definite consensus over it. The mean radiation dose is 12 gray. The range has in the reported literature is 8 to 25 gray. The limitations are optic apparatus and the hypothalamic pituitary axis, because the optic apparatus in a single session should not be exposed to more than 8 gray of the radiation. It also depends on the consistency of the tumor. In the solid tumors, the long-term tumor control and the progression-free survival is 90%. With a mixed tumor, this has gone a little wrong. For the cystic tumors, it's 60%, and for the mixed, it's an 88%. The tumor control was found good in the tumors when the radiation given was more than 12 gray. If you have used less than 6 gray, which has been used in some of the literature because of the large size or because of the constraint of the optic apparatus, 85% patients recurred. So to show the effect of the dose, I can just give you two examples. Like the Pittsburgh group, they used a mean marginal dose of 16.4 gray, showing a progression-free survival of 80% with a complete resolution in 40%. They had a cyst enlargement in their cystic craniopharyngioma cohort of the 30%. Compared to this, Bordeaux-Lippitt's group gave 5 gray. So it was it was a significantly less progression-free survival of 36% with a complete resolution only in 23%. Ironically, they had high recurrence and high visual deficit also. The reason because they treated a tumor volume of 8 cc and above. So that was a relatively large tumor volume which they treated. Sometimes we just get a solid remnant like this one. And this becomes a tough call because it's a completely solid one. They are usually considered to be benign. And most of the literature suggests that we should just wait and watch and give a radiosurgery only when the tumor is progressing in size. If I have a cystic remnant, then I have to look what kind of a cyst is it? Is it predominantly solid, some cystic, or is it a mixed solid and cystic? Or if it is a completely cystic tumor. If it is a completely cystic tumor, it's a real challenge, as just in this particular session, we found that there is no consensus opinion and there is significant frustration in the treatment with the different options. These options can be given as an standalone treatment or as a concurrent therapy. The literature is not sure over it, and there is no definite answer to this question. As the response to the radiosurgery for solid versus cystic, the UPMC experience of the Pittsburgh group, they have found 46 patients with a tumor volume of 0.07 to 8 cc with a dose of 13 gray as a mean marginal dose. The solid tumors again had a very good response, while the cystic tumors had only 68% tumor volume reduction. Especially it becomes difficult with the larger and multicystic tumor. They have less satisfactory outcome with the radiosurgery. And the tumor progression post GKRS is often related to the further enlargement of the cystic component rather than the solid part. Does it make a difference if it is an adamantinomatous or a papillary? No literature evidence over it, but probably a less cystic one should give a better response. That's an indirect evidence. My patient has a residual lesion near the optic apparatus. What should I prefer, SRS or SRT? Well, with the hypofractionated SRS, with the current frameless gamma knife, with the Icon machine, we can give it in 5 fractions. So the radiation exposure to the optic apparatus would be less. And definitely we have other machines like Proton, Dr. Rakesh Jalali just told, and in those cases, we can take care of these patients with a high precision also. So there has been a comparative analysis of SRS versus SRT. And Lexel SRS is associated with the fewer complications when compared to the other treatment modalities. Most radiosurgery series report a lesser rate of new hormone deficiencies compared to the fractionated radiation therapy, which has been largely abandoned since 2000 because of the late neurocognitive dysfunction. Adjuvant SRS also helps patients avoid the immediate complications of the attempted gross total resection. A favorable quality of life outcome was most frequently demonstrated in patients who had tumor regression after radiosurgery, and the radiosurgery was most effective for smaller tumors and those with a complete radiosurgical coverage. An important issue which, as a clinician, not only as a surgeon, we have to follow is that these patients should have a good quality of life. So the Pepys circuit, hippocampus, and the temporal lobes, they shouldn't be exposed to the radiation, and that's why we have to choose our radiosurgery machine in a way so that those areas are preserved and the life should be the worth living. Which is a better knife? Well, practically, whatever the knife your hospital has a better knife, because the literature is not showing any very great difference over the overall survival and the progression-free survival. Yes, there is difference in the endocrine outcome, hormonal outcome, and the neurocognitive outcome. So the proton and the photon, this debate is going on for a very long time. There is a significant body of literature now with a long-term series with the radiosurgery, and now with nearly around 2 decades experience with the proton, which is coming very significantly. But this article published in 2014 in Red Journal, there was no difference in the overall survival, and there was no difference in the toxicity profile. So what we follow, we just follow this approach similar to the John Varlotto, and primarily with the surgery with the maximum safe resection, followed by the radiation therapy. My experience with craniopharyngioma is limited to the 16 patients so far, and the progression-free survival in the patients which we could follow beyond 5 years, it was 76%. The combination therapies of the BRAF inhibitors, either as an standalone or with SRS as a concurrent therapy, the literature is not sure over it, because the earlier literature with the BRAF inhibitors was for the melanoma, and they used to withhold the SRS for a day to prevent the chances of the radiation toxicity. Would it be similar in a case of craniopharyngioma or not? The literature is yet to come up over it. So in conclusion, craniopharyngioma is a challenge in true sense, and because you need a holistic treatment for the patients, not just a good resection in this. Even a subtotal resection is acceptable if the patient remains satisfied in other domains. What remains important to monitor is tumor control, hormonal control, neuropsychiatric control, sexual well-being, and behavioral growth. And frequently, one or the other domain is compromised if you are overzealous on just a surgical front. Thank you very much.
Thank you, Dr. Manjul, for that wonderful